What are the histological features of Crohn's disease? There is a transmural inflammation of all the layers of intestine with chronic inflammatory self-infiltrate, non-caseating giant cell granuloma may be found in some patients. What is the medical treatment for Crohn's disease? Corticosteroids. Oral corticosteroids in mild to moderate Crohn's disease. Parenteral corticosteroids is indicated in severe Crohn's disease. Sulfasalazine useful in mild to moderate Crohn's disease. And immunosuppressive agents as if you reduces the dose of steroids. Refractory disease monoclonal antibody infliximab has shown marked response to complicated disease. Antibiotics indicated when there is complication of abscess or fistula formation. General treatment: maintenance of nutrition, correction of anemia, hyperproteinemia, and electrolyte imbalance. What are indications? What are the indications of surgery in Crohn's disease? Surgery is usually indicated for complications like recurrent intestinal obstruction, perforation of fistula formation, failure of medical therapy, fulminant colitis, malignant change, and perianal disease. What are the options of surgical treatment in Crohn's disease? Surgical treatment involves resection of grossly involved segment of bowel responsible for a complication. Wide resection of bowel is not indicated in Crohn's disease if there is normal looking bowel ends. At the end of resection, there is no intra-abdominal sepsis. Primary anastomosis may be done. If there is significant intra-abdominal infection, proximal ileostomy is to be done. The options of surgical treatments are small segmental ileal or colonic disease, segmental resection, ileocecal disease, and ileocecal resection with ileo ascending anastomosis, intra-abdominal abscess due to ileocecal disease. CT guide percutaneous drainage of abscess. Once the abscess has settled, local resection of the gut. Caseation, necrosis with conversion of damaged tissue into a soft chewy substance. Caseate. Colonic Crohn's disease surgery is indicated with shorter duration of symptoms. The extent of surgery will depend on the extent of the disease with rectal involvement. Total proctocolectomy with permanent ileostomy is advanced. Total colonic and rectal disease. Total abdominal colectomy with ileorectal anastomosis. Total abdominal colectomy with ileostomy and closure of rectal stump. Hormones precision. Localized structuroplasty. Barium will follow through. Recurrent appendicitis. Right colic fracture. Ascending colon. Cecum. Appendix. Multiple filling defect within lumen of appendix. Transverse colon. Ileum. This one of the scarogram of barium will follow through the series taken 5 hours after ingestion of barium, showing ileocecal resin. However, barium will follow through recurrent appendicitis, right colic fracture, transverse colon, ascending colon, cecum, appendix, and ileum, multiple filling defect within the lumen of appendix. This is one of the schiogram from barium will follow through. Series taken 5 hours after ingestion of barium, showing the ileocecal region and right half of the colon. The appendix is visualized, but it shows multiple filling defects in the lumen suggestive of fecal legs. This appearance suggests a pathological appendix. How are fecal legs formed? Fecal legs are formed by inspissated fecal matter. calcium phosphate, bacteria, and epithelial debris. The incidental findings of fecal in appendix is indications for prophylactic appendectomy. What are the etiological factors for development of acute appendicitis? Bacterial infection. There is usually mixed growth of both aerobic and anaerobic organisms. Obstruction of lumen of appendix by fecal foreign body and fibrous structure is an important predisposing factor. Familial predispositions. Aesthesia, capacity of sensation and feeling sensibility. What is the classical presentation of patients with acute appendicitis? Periumbilical cord pain, which later shifts to the right iliac fossa, coughing or sudden movement exacerbates the pain. Fever, usually there is mild rise of temperature. In early stages, there may be no fever. High temperature greater than 38.5 degrees centigrade usually suggests other cause, mesenteric adenitis or urinary tract infection, nausea and vomiting signs, low-grade pyrexia, muscle guarding. In the right iliac fossa, cutaneous hyperesthesia may be present. In right iliac fossa, localized tenderness or rebound tenderness. In right iliac fossa, rousing sign, deep palpation. In left iliac fossa may cause pain. In right iliac fossa, and then rousing sign, deep palpation in left iliac fossa may cause pain in right iliac fossa. Sore sign, inflamed retrocecal appendix may cause sore spasm, and patient with lie within the right hip, flexed for relief of pain, hyperextension in right hip joint may induce abdominal pain. Obturator signs occur cope and flexion and internal rotation. The right hip joint will cause pain in hypogastrium. This is due to inflamed appendix lying over the obturatory internus. Obturatory internus. Obturator internus. What are the peculiarities of retrocecal appendicitis? Classical pain in the periumbilical region and shifting of the right iliac fossa is usually absent. Pain may be felt in the loin, tenderness in the right iliac fossa may be absent. Instead, there may be tenderness in the right loin. Such sign is usually present. What are peculiarities of pelvic appendicitis? Pain and tenderness may be elicited in hypogastrium rather than right iliac fossa. Inflamed appendix, in contrast with rectum, may cause diarrhea. Inflamed appendix is contacted with bladder may cause frequency of micturition. And rectal examination revealed tenderness in parts of Douglas, especially on the right side. What are peculiarities of posterior appendicitis? Classical pain often felt through the right umbilicus. Diarrhea is an important feature as the inflamed appendix lies in contact with the ileum. Then, what laboratory investigations may help in diagnosing apart from detailed history and clinical examination? Following laboratory investigations may help in diagnosis and may reduce the number of negative appendectomy. The total and differential white blood cells WBC count, elevated count with polymorphonuclear leukocytosis, C-reactive peptide, elevated in acute appendicitis. What are the rules of imaging investigations in acute appendicitis? Ultrasonography effective in detection of distension of appendix but cannot detect perforation. Interpretation is operator dependent. However, ultrasound is not superior to clinical examination in diagnosis of acute appendicitis. CT scan beneficial for evaluation of patients with suspected recurrent chronic appendicitis. CT scan has high positive predictive value for diagnosis of acute appendicitis. How will you treat patients with acute appendicitis? The area of treatment is appendectomy. What is the role of conservative treatment for acute appendicitis? A prospective study has demonstrated that 2 days of parenteral antibiotic therapy followed by 8 days of oral antibiotic was as effective as surgery for acute appendicitis. However, the recurrent rate of appendicitis requiring surgical intervention within 1 year was 35%. In view of the high recurrence rate, surgical treatment is preferred for treatment of acute appendicitis. What are the indications of appendectomy? Acute appendicitis, recurrent appendicitis, mucosal of appendix, endometriosis of appendix, appendicular diverticulum, carcinoma of appendix involving mucosa and not involving the base of appendix. A small carcinoid tumor of appendix confined to tip or body of appendix. What are techniques of appendectomy? Open appendectomy, laparoscopic appendectomy. What are incisions for open appendectomy? McBurney greater incision, lance incision, midline incision, right paramedial incision. Describe the steps of appendectomy.